Okay, now I can take my note down that says record the meeting. Well, welcome everybody. Good to have you here. So you've got something to talk about, Andrew, I hope?
Oh, we did a IMHA case this past week,
Uh-huh.
and it was a
One of my favorite topics.
it was a dachshund, um, and she came into us last Wednesday, and or maybe she came in on Tuesday. Between Tuesday and Friday, Wednesday and Friday, had 5 blood transfusions,
Yeah.
and so on Friday we did TPE. We exchanged 1.5 plasma volumes.
So she came into your practice on Tuesday and you waited until Friday to,
Well, she came in through the ER on Tuesday. We got her on Wednesday, realized on Thursday this wasn't great. And yes, on Friday, pulled the plug and
well,
did.
it's the same at every hospital, so I'm not pointing fingers, honestly. I'm not.
She went through more blood product, I think, than we realized she was going to. Um, and it was weird because her bilirubin never really got, I don't think it ever got above 2, but she just kept destroying every transfusion we gave her. So we did TPE and exchanged 1.5 plasma volumes on Friday, replaced 100% with plasma. Um, Wrote it out over the weekend. I think she needed 1 transfusion over the weekend, and then we did TPE again on Monday, another 1.5, just about plasma volumes, 100% plasma um, replacement, and she went home on Tuesday and looked great. Um, I mean, she went home on Wednesday. We kept her for 24 hours following the procedure. She went home on Wednesday. Honestly, the biggest challenge we had with that case, um, so she was on Plavix, and I heparinized her prior to um the TPE, but we use the Amicus, so it's a citrated platform. And so she wasn't like therapeutically heparinized. She just had some heparin, and then between procedures on Friday to Monday, we hep locked the catheter. And in hindsight, I would have evaluated the catheter more closely and changed the hep lock every day. But we didn't. And so on Monday, when we went to start the procedure, um, she had clotted the inlet line. And of course, I found that out as we were about to hit go on the procedure. Um, So I had to back the catheter out about 2 centimeters, and then we had good flow till about 70% through the procedure, and then we lost the inlet line. And so I futzed around with it for about 10 minutes, maybe not, maybe like 3 minutes. Couldn't get it to work, and so I reversed the lines, and we ended up pulling off the return line for the last third of the procedure, and returned back through the inlet line, and that worked until about you know, we were 95% through the procedure and both clotted, and we said, okay. So we just ended where we were. Um, and otherwise I think it was uneventful. So I think if I could, and then as she was leaving, I was like, let's add some rivaroxaban to her. So
What was the last statement?
let's add some rivaroxaban to the Plavix protocol. Um, so I think in hindsight, if I could do it again, I probably would have more aggressively anticoagulated her with heparin on top of obviously anticoagulating the circuit with citrate. I would have continued to check that catheter every day more closely throughout the weekend and re-heparinized the catheter every day to make sure it was still patent and I wasn't surprised on Monday morning. And I probably would have added rivaroxaban as soon as we got the catheter placed. To
So
again just
let's go over a couple of these things. Number one, on these dogs, I've learned that we just heparinize all of them, whether the circuit is citrated or not. because the machine may be anticoagulated, but the dog is not, and they're usually hypercoagulable.
Yeah.
So we just automatically heparinize them the same way we'd heparinize a dialysis patient.
A CRI during the procedure, or always?
Yeah, we give them a CRI. We treat them just like, you would a dialysis patient. So we'd give them a bolus and then top off their heparin to keep their activated clotting time at some target. And then usually we'd put that target probably a little higher than we would for a dialysis, unless it was a real nasty lepto or something like that. And just make that a standard protocol, because you'll run into this problem every time. And I think particularly on these little dogs. So what was your flow rate? I bet it was 20 mils a minute or
No, it was 10. It was terrible.
10 mils a minute. And so you've got a trivial little flow rate coming out, and probably there's a segment. I don't know how the amicus works, but on the Optia, there's probably from the end of the catheter to the site where the citrate actually meets the blood, there's probably 7 or 8 mils of blood in that volume.
It's right at the end. It's very minimal. It's maybe like 3 or 4 centimeters.
All right. So, but if you include the catheter, and then in that segment, then there's a period in the circuit where there's no anticoagulation in these hypercoagulable patients, and that's where they typically clot. And usually we'll get an inlet low alarm, and then we just have to flush the catheter back. And sometimes there's not a good place to do that on these TPE circuits, so that we usually have a stopcock at the inlet. Or now the Optia circuit has an injection port there, so you can do that. Or you'll disconnect it and you'll get a big worm clot out of the circuit. So it's really, really, I think, in these extremely hypercoagulable and highly inflamed patients, that you go ahead and heparinize them, as well as because the machine was probably fine. You were anticoagulating the machine really well with the citrate, and where all your problems were at the access. And sometimes those clots will break off, go downstream, and they'll clog up a filter. Like on the Optia, there's a filter in the inlet filter before the pump, and you'll plug that filter up, and then you're almost stuck, because there's very little options of blasting that. You can't suck it back because the pump acts like a clamp, and you can't take the pump segment out. I've got a way that I found that we can blast those clots out of there. But typically that's what happens, is that a clot will form in the catheter or in the early segment. It'll break off, flow down the inlet side of the machine, and then obstruct something, usually a filter that's in there before the pump. So that's number one. And then what were you using as a hep lock in your catheter? How much heparin?
0.9 mil. Like, it was undiluted heparin.
So 1,000 unit per mil. Yeah. Okay. That's probably what I would have used too, until it clotted the first time. Then I'd increase that a little bit.
Well, we pulled the catheter after it clotted the first. Like,
you couldn't flush the clot back.
Say it again.
Or you couldn't flush the clot back, or you couldn't suck the clot out.
Well, no, I couldn't suck it out when I pulled the catheter out 2 to 3 centimeters. I don't know if it just changed the position of everything relative to the clot, or relative to the catheter, the end of the catheter up against the vessel wall, or in the heart. It was in the heart. So then it flowed okay for like I said, 2/3 of the procedure. And then I reversed it after that. And then we pulled the catheter at the end of the procedure, because both the inlet and the return were giving us problems at that point.
And it was probably the inlet limb of the catheter that was clotted, I suspect.
Initially, yes.
Yeah, and the reason for that is that you know that segment of the catheter has side holes typically, and the blood will flow through those side holes out the end hole and wash out the heparin that's in that piece of the catheter. Whereas you may not have that on the return side. Some catheters on the return side, there are no side holes, there's just an in hole. And so you don't wash out that, because these clots almost always occur on the inlet side.
Okay.
And so you flush the heparin out of there, and then that the heparin that's in other ends of the catheter diffuses down, it gets washed out. And so you end up with that segment of the catheter that really doesn't have adequate amount of heparin in it. That almost typically happens. A lot of times there are ways that you can suck those clots out without introducing a lot of air into the system. Or if we can't, then we just blast them back to the lungs. I mean, that's what the lungs are for, is to collect the clots that we generate with extracorporeal therapies. And usually you don't get into any trouble with that if they're tiny clots. If they're big clots, I've only had one adverse. I did have one dog long time ago that developed a pulmonary necrosis and then got a pneumothorax. But we resolved that. But usually the clots are small enough, they're not going to cause a huge embolism that's going to cause the patient to die. This one, it went into some small arterial and then necrosed a piece of lung, and then got an air embolism from that, or when it broke. But a lot of times there's an art to getting those clots out of the catheter. I mean, there's a huge art to that you probably know very well. I'm also going to take exception to another thing and you only did about 3 plasma volumes of total treatment. I personally feel that that's too little, even though the patient responded. If you looked at it the next day, he might have had a big drop in his red count after that. I think that you need to give these animals at least 4 and sometimes 5 plasma volumes before they're really fixed. And I say that from 2 pieces of experience. One, we've studied so many of these animals, and in the study that we've done that we haven't published yet, the animals that got less than 3 treatments or less than 4 plasma volumes of treatment, if they got 4 plasma volumes of treatment, we had a 92% success rate compared to 60% with medically managed cases. If they got 2 but less than 3, they still had a statistically significant advantage over conventional medical therapy, but it wasn't nearly as great as it was for the patients that had more than 2 treatments. And then the other experience that was just anecdotal that I don't have data on is I think that we see a higher frequency of reoccurrence in the patients that get less treatment than the ones that get more treatment. So I just make it an automatic rule that I'm going to do at least 4 plasma volumes of treatment. I know Dr. Palm likes to, if they get better, she gets them out the door. But I don't think at the moment that's the best. And this is just my opinion. It's not, well, we can prove it a little bit with our statistics, but I don't think that's the best treatment option. I mean, if there's no other way that the patient could afford a 3rd treatment, and the dog is doing well, I guess you quit. But I would usually estimate 4 and deliver at least 3 treatments. Just personal experience.
And maybe a reflection. I've been trained by you and kind of your lineage of other mentees, so I kind of approach it the same way. And just from my, I look at the agglutination if they are agglutinating, and I can see after the first 2 treatments, because I'll do day 1 and day 2, try and get a 1.5 plasma volume exchange, and I'll get resolution of the agglutination after those 2 treatments. But then I come back the next day or the following day when I do the third treatment. And there's often a little bit of agglutination that kind of sneaks back in. So there's still active disease. And that's where, I have convinced myself that the folks that I learned from knew what they were talking about, although we already knew that. So I'm with Cowgill on that one too.
Yeah, and certainly after the second treatment, there's usually the next day. There may even still be a little bit of agglutination at the end of the second treatment. Usually it looks pretty clear. I mean, often after the first treatment, the agglutination is gone at the end of the treatment. It'll be there the next morning. And again, an animal that buzzed through 5 transfusions, I probably would have treated 2 days in a row. And again, we're not pointing fingers. There are a lot of logistics that come into this, but I would usually treat them at least 2 days in a row to get real good control of the disease. So what happened between so you did have to transfuse the dog during the weekend.
I think we did a transfusion on Sunday.
Yeah, and you may have been able to avoid that transfusion if you had done them like Friday, Saturday, or something like that.
Yeah, I didn't have the staff. I couldn't
Sure.
logistically do it this weekend.
Yeah. And that's I mean, that's reasonable. You can only do what you can do. But typically if they're really bad like this and eating through 5 transfusions, number one, that's going to really exacerbate their hypercoagulable state, plus all the other DIC stuff that they might be generating. And typically those are bad ones that probably getting 2 or 3 treatments in a row stops the disease process pretty quickly.
Do you guys modify? I mean, again, it sounds like there's kind of this ideal 3 that we've been shooting for, although it sounds like we need a little bit more outcome-based data to really hang our hat officially in that. Do you guys modify it based on how far they're into the treatment? Like, obviously, in the perfect world, we'd ideally recommend this as more first line. Sometimes the practicality is of when we get the referral or how long they've been treated, or sometimes for a client, they just have to see it. It's not going to go well with just the single transfusion. Do you guys modify it? Like if they're already, 7 days into dual immunosuppressive therapy, if they're only kind of autoagglutinating, but the client decides at that point, like, is there a juncture where you're like, we're going to shoot for 3 because no matter where they are in the treatment of the disease process, that makes sense? Or are you almost like, if they're refractory and they're still having that much level of transfusion dependency and we're already on day 5 or 6 of immunosuppressives, then that makes me more likely to want to do the 3 treatments?
Yeah, well, I'd give a couple of answers to that. Number one, in order to get the antibody reduction down to some big number, you need 5 to get it down to essentially 0. You need 5 plasma volumes of treatment at least. And that's not counting the fact that your immunosuppression probably hasn't kicked in yet, and they're probably still generating antibodies. The good news is, if you get rid of all those antibodies, and you can stop the production, they're gonna be gone for 3 weeks, likely. You won't have any for 3 weeks. Where if you come in with immunosuppression and stop the production of antibodies, but don't do plasma exchange, you still have antibodies that are hanging around for 3 weeks. And so if your red cell production doesn't meet your destruction, then their hematocrits are gonna drop. So that was point number one. And the way you stop the disease process while you're waiting for your medical therapy to kick in is to get rid of all those antibodies. And the way to do that is with plasma exchange. So my attitude on it now, I believe it's a first line treatment. And when they get referred in, or if they come into your hospital as a primary case, I'll allow 2 transfusions because personally, if they're really bad, I mean, if they come in and the hematocrit is 9, I think you ought to plasma exchange them first. But if they're reasonably stable, because some of them, the milder ones, you can manage medically, obviously. And so, but by the time you're reaching for your 3rd bag of blood, you really ought to be, in my opinion, knocking on the extracorporeal door to get those patients treated. So I'll allow 2 transfusions, and then by that point, you're not going to do any good. Just like this dog, went through 5 trans. We had one in our hospital not too long ago. Maybe it was in the San Diego hospital. They went through seven transfusions before they got around to doing the plasma exchange. And again, unlike your dog, most of the time by then their bilirubins are 30. They're more hypercoagulable. They've got all kinds of other reactions to all the blood products and the blood destruction, and that they're tougher to treat at that point.
So if
So
you
go
didn't
ahead.
have a time dependency or a staffing dependency for those 3 treatments, given the rebound, in your mind, having a treatment day 1, day 2, day 3 in a row, or day 1, day 2, skip a day, day 3, like if there wasn't like a weekend to consider or staffing to consider.
Yeah, so and again, we just started with day 1, day 2, day 3 or 4. Not day 3, but day 4 or 5. That's the way we started. But now, when I look at the data, and so we had something like 30 to 32 dogs in this case control study that I keep alluding to, but haven't gotten published yet, hoping to get it written by the end of the year, compared to 82 dogs that were medically managed, time controls. And so we picked, for every dog that we treated, say in 2008, we picked 3 dogs from that, randomly picked 3 IMHAs from the hospital that were medically managed. And so we had time controls and case controls for each one. And when you look at that, there's, even if you do day 1, day 2, in some animals, there'll be a big drop between the second treatment and the third treatment if you wait a day or 2 in between. So you haven't got those patients quite controlled yet. And those are the ones that you can just smell, they just smell bad when they come in. Some dogs, by the second treatment, they're on their way and they're going. They still will drop a little bit. And as Jethro suggested, there's still some agglutination, but you really top them off with the third treatment that maybe is on day 4 or 5. But there'll be some that'll have they'll have a 50 or 60% drop between the second treatment and the third treatment if you wait a day. And that animal may need to be transfused. And you just make a decision. What you would do is to look at the day after your second treatment, and if the hematocrit's drop, then I'd treat them again on that day. If the hematocrit's pretty stable on that day, then I'd maybe wait until day 4, day 5, particularly if it's on a weekend. But if you see a perceptible decrease in the hematocrit between the second treatment and the next day, or you still have really gross agglutination on that day, then I would treat them a third time, and then they're pretty well. Then they just take off and go. Occasionally, but sometimes if you do 3 treatments in a row, you may have to do a 4th treatment, on day 7 or something like that. If they're not, because those are really bad patients, they're really, really horrid. And some of them will need a 4th treatment, but not many. And you then after the 4th treatment, they just recover. It's been
Your protocol now is primarily treat days 1 and 2 back to back pretty consistently, and then figure out the day.
I do it routinely, day 1, day 2. Then you make a decision on day 3 whether they're stable enough to wait another day. And there's an advantage to that, because then you get redistribution of antibodies that aren't in the vasculature. And so that's an advantage. But if they have a huge drop in their hematocrit, or they still have really pretty severe agglutination on day 3, then I think it's more advantageous to treat them on that day, and that will typically avoid another transfusion.
Yeah, I have the conversation coming through the door, like the commitment is 3 treatments over that estimated timeline. And I warn folks, sometimes I've needed to go to a 4th treatment, or I've had 1 or 2 that are refractory to treatment altogether. But that's the plan kind of from the start, just like I do like with my dialysis cases. I'm like, listen, we're gonna aim for 3 to 4 weeks, and some end up recovering sooner and some don't. But that's my minimum commitment that I'm setting folks up to expect, is that 3 treatments over those 4 days. And sometimes that 3rd day is a day off, and sometimes they can be an outpatient that day. oftentimes they're in the hospital. But like Dr. Cowgill says, it's a little bit of a wild card day for my end as well. If they're still chewing through things and they need another transfusion, then they're that much on fire, then I'll treat them 3 days consecutively. And I think JD is doing 3 days in a row as well, but I think there's some variability there.
Yeah, and so what hematocrit did you send the dog home with?
34%.
And that was post-transfusion, or that was?
That was no, just post the second. We didn't we had to blood prime the machine every time, and then I rinsed back, so she essentially got a little mini transfusion at every TPE as well. But
it would have been really interesting to see the dog the next day and see what the hematocrit was the next day, or what it is now. And sometimes, the dog might be well, and I would suspect that hematocrit probably dropped from the 30s down into maybe the mid-20s. And then without the third treatment, they kind of smolder, coming up, because they still have ongoing destruction, but they have enough red cell mass to be stable. So you may get away with just the 2 treatments, or you likely have and will, but the animals aren't as well managed, I think, with just 2 treatments. And again, it's anecdotal with me at the moment, but I think the animals that we treat less than 4 plasma volumes, and I think that's the way to look at it more rationally than the number of treatments, is the amount of plasma volumes that you've delivered. I think some of those animals have reoccurrence sooner or more frequently than patients that get more treatment initially.
Drew, wasn't your dog initially also non-regenerative? And then you started to see regeneration after this, was it the second treatment or the first treatment?
Well, I could pull the data up if you want to look at it. Let me, maybe if somebody else talks for a minute, let me pull up I can show you all of our data that we have from that study. And let me just pull that.
Again, while he's looking for his official one.
Well, that's it. But I've got all the hematology and all that stuff. But you go ahead and start there if you would, Jethro.
Yeah, I mean, like I said, like my own biases, I've been trained in this vein and kind of adopted this data, which if you need help getting this out there so the rest of the world has it too, I think it's so valuable to look at this graph here. But and not to put words onto it, Dr. Cowgill may change that, but you look at the difference between this was the dogs that got, I think, the 2 treatments versus the 3 or more. And again, back to plasma volumes exchange, like I'm aiming for 1.5 per treatment to try and hit 4.5 over the 3 treatments, standard over those 3 treatments over 4 days. But it's variable in there, and sometimes my plasma or the treatment's not going as well, and so I get 1.3 plasma volumes or 1.2, and I'm okay with that as long as I'm getting over 4, cumulative. But I think, I mean, this is really data that I share with my house officers and when I talk about this stuff, because I think it's really nicely illustrative from a standpoint of the number of treatments that really do help us know that the outcomes are better when they get that 3 or more.
And I admit that everybody's waiting for there to be some evidence published, and this is the best. I mean, there's some case reports out there, but this is really the best evidence. I mean, we had, I guess it was 69 dogs in the control group, the medically managed group, and then and we had 32 dogs that we treated with plasma exchange, and I was going to. My attitude is that particularly for this disease, 2 treatments is not enough. And I was going to take those animals. I was going to make the entrance criteria that they had to have more than two treatments. And then I thought, well, that's not really fair. So we added those animals in, and so the two of the animals that only got 2 treatments died in the hospital because they were, I guess all 4 of those. Well, 2 of them died in the hospital, but we had 28 dogs that had more than 3 plasma volumes. I'm almost trying to find this presentation. but I haven't found it yet. And I should be able to find it really easily, but I just hasn't come up yet here. Oh, here it is, maybe.
I think this data helps us, right? Like when we're thinking of the hospital, because we're so used to sort of thinking of certain things as a as needed treatment basis versus if the treatment is really 3 treatments. I mean, obviously compared to your controls, that middle group still had some benefit. So to your point, like if an owner's like, I can't do all 3, but I can do 2. But I think it also helps us have the conversation because we like to preemptively say like the total cost is likely to be X. Like you were saying, Jethro, about dialysis cases. It's like there's no point in doing, having a bad AKI and doing 2 treatments. Like it doesn't really, you know what I mean? All the other things that come with it. And so I think for us, having a lot more data to come to it makes it easier for us to come to the clients and say the recommendation is the 3 treatments, not the as you treat as you go. Because it's sort of like we have approached it as a treat as you go just so that we could get some, sort of concurrent intervention that isn't just immunosuppressive therapies. But I do think it's helpful to say there's a marked difference, which this graph sort of suggests.
But look at the odds ratio for death.
Yeah.
Six, almost 7 times more likely that you're going to die without the plasma exchange. This is 30-day survival that we looked at, 30-day survival.
Is this euthanasia death or death?
Pardon me?
Is this euthanasia and patient death?
Yeah, most of them are, well, it's some of both. We did try to exclude patients. I found the presentation now, Jeff.
You got the whole. All right, I'll stop sharing here.
Let me find out why I was showing it on my screen in a way.
I mean, I think, and I don't know if this, you hit on it a minute ago, and I just want to like come back and highlight that the number of plasma volumes exchanged, like if you needed to do more plasma volumes, let's say you could only do 2 treatments, but you made one of them 2 plasma volumes or 2.5. Now you're going to get your rate of return on that as you're getting further and further down that curve for the cost of your plasma and your exchange volume is going to be less and less. But if that helped kind of put it into 2 treatments, but you were just doing more clearance of those things, you're going to get further down that percent reduction of the toxins of interest or your immunoglobulins. But I think, the way I frame it for folks as well, and kind of how Cowgill said it, like we're clear in the weapons, like the immunosuppressive drugs or modulatory drugs are just trying to shut down the system from making more of them. But whether they've been on them for a week or whether they've seen them 1 day of them, all those circulating weapons of the immune system are still active and on fire, and the complements, cascade, all of those things that the plasma exchange removes. Is clearing the manifestation of the disease, while the immunomodulatory drugs really just try and shut down the production of those things. And you're not going to get 100% shutdown of immune production in a couple of days anyway. So there's still ongoing production. That's kind of the logic and the framing I put to folks, and they seem to be able to grasp that in a reasonable way.
Yeah, we just have the cost of hospitalization, which is substantial in our private practice hospitals, and so. It's like debating, is it, doing the 2 treatments at the longer time period and more plasma volumes more beneficial? Are people sending them home between treatment, 2 and day 4 or 5 to offset that cost? Because it can be upwards of, 15 to 2K to stay in my hospital per 24 hours, right? So when I'm looking at the overall cost for these clients, it's, maybe the point is, for us, 2 treatments if we can take out hospitalization. And you guys are probably more comfortable sending home patients because you're used to dialysis patients than we are. Like how many of the ones that you guys have done or in these studies did you treat and then continue to have in the hospital, or have go home and then come back for that day 4 or 5 treatment? Or was it just really based on checking your
I can show you that if I can get my screen to share here. It starts sharing and then it stops. Is it sharing now?
I mean, if my patient's stable after those first 2, I'm not uncomfortable having them go home. There's always that question mark, and usually I'm dealing, on my end, the reluctance is because residents who are less experienced are kind of managing primarily the cases, and so they're a little uncomfortable sending them out the door. Well, what if their crit drops? And then we have some capacity kind of considerations as well. And if they have to come back and be admitted, maybe there's not a spot that we can squeeze them in anymore and things like that. But I have no hesitation to say, if they're stable and everything's looking kind of kosher, like your guys' dog, go home for a day and come back on day 4 and we'll do an outpatient treatment. Because I usually, and if you look at, some of the recommendations, I would send them home with their catheter in place. Granted, your guys had all the clots and everything. I'm a little bit stitious, or a lot superstitious, and so I keep their catheter in usually until I've gotten out of 5 days or so, 3 to 5, because I don't want it to go too long without changing out those hep locks like you guys were already talking about, and do that recheck and then pull a catheter usually at that point, just in case there's a 4th treatment that's needed or they have some kind of step back.
So am I sharing now? Can you?
We're seeing it, yeah.
So let me show you this first. This will scare you. If I can get this move. So this is the inlet line coming from our catheter here on the optia, and this is the citrate line coming down, and it joins here. And so between this line and the catheter, there's probably 4 or 5 mils of volume in there. And watch this line. So this is an IMHA patient, and look at if this movie will play. Well, it's not gonna play. Here it goes. Look at what's coming out. Look at what's coming out of that dog's vasculature.
Oh my gosh, we've had that too. And like we get tons of reservoir alarms from the clumping, and it's crazy.
And I mean, this is really scary. I have to admit, though, Urs Giger thinks that this is an artifact, but it's no artifact. I mean, that he thinks this is an in vitro effect, but there's not enough volume there. I mean, you see this coming right out of the end of the catheter, so there's not been time for this to occur in that tubing set. But I mean, that gives you a little bit of fright. So if we get into so this, I like to show this picture as well. And so this is kind of what you expect to happen with a single pool model with your plasma exchange. And so the sweet spot is usually around 1.2 to 1.5. And again, on a little dog like you guys had, a little dachshund, we order the plasma based on what we think we're going to need, and our blood bank, the plasma bags don't have 150 mils in. Some of them have 120, some of them have 180, some of them have 200 mils. And so when we get the plasma, we weigh it to find out exactly how much plasma we have. And we get out to 1.5 plasma volumes, and we still have some plasma left. Well, we go ahead and deliver that plasma. So some of these animals will get 1.8, maybe sometimes even more than that. But this is the sweet spot. But to get way down here to the bottom, you need to do 4 to 5 plasma volumes of treatment. And then I like this picture because it shows what happens during the course of your first treatment. You go from this stage of disease to this stage of disease at the end. And sometimes you'll get there, even at 0.5, 0.6 plasma volumes of treatment. This animal at the end at 1.5 plasma volumes exchange had really almost resolved all the agglutination. The other useful information that comes from this is that, at the beginning of the treatment, you cross match against 5 donors, and none of them will cross match. None of them. But by about 0.5 plasma volumes of treatment, those animals that were incompatible at the beginning of the treatment are now compatible. And so if we can, we try to hold off giving any of the transfusions until we're later into the treatment, so we don't give those red cells and get them immediately coated with antibody. And so then you can go ahead and if you cross match, at the end of the treatment, animals that were incompatible at the beginning, most of those animals will be compatible at the end of the treatment, and they'll hold on to that blood. So this goes to the point we've been talking about. So at the beginning of let's see. So here's treatment 1, and the animal looks pretty non-agglutinated, and then you come back the next day and it looks like this. The end of that treatment, it looks better, just like it did on day 1. And then by the third treatment, sometimes there's still a little bit of agglutination on the really bad ones. And, you know, on this day, on day 3, then I'd ask the question, yeah, does that, you know, would we do better if we treated on that day? Has the hematocrit dropped, you know, between day 2 and day 3? This was actually day 4, so there was a gap in between, like a 2-day gap, and you can see the disease is not resolved yet. But when you look at day 7, you know, treat on this day, now you've gotten rid of all the antibodies, and then on day 7 you don't have any evidence of agglutination, where there's still some antibody hanging around before you did your third treatment. Oh, and this just shows the change in cross-match compatibility, you know, as you go out from various treatments. But this guy that was 4+ positive to this donor at the end of that treatment may be compatible with that donor blood. All right, so let's just get into our protocol here, which should be in this. All right, so these were dogs, and dear Sean, our technician, he screened about 1,200 IMHA treatments, and these were our selection criteria. They were dogs presented to UC Davis or San Diego, although we really didn't use any of the San Diego dogs because they didn't have very good records. Between 2011 and 2018, and they were continued on their current therapy or they were revised. Most of these animals came in, and our hospital likes to use cyclosporin and pred. So if they were on mycophenolate or something else, they usually got changed over to cyclosporin. And let's see, there was another, I think there was something else here. So we had 3 dogs that were excluded because they had inadequate. This was when I presented it in 2019, and then I subsequently came back and I included all the animals that we had done plasma exchange on, and so this part wouldn't have been part of the inclusion or the exclusion criteria. So. And again, at that point, he'd only looked at 400 cases, but ultimately, when we got the final data, I think it was something like 1,200 IMHA patients. And then for the control group, we looked at all the animals that had IMHA in that year, and then randomly selected 3 or 4 times the number of patients that we had that were treated with plasma exchange during that year. Let's just go to here. So here are what these animals came in with. See, you know, I need to get you the other one, because now we have 32 dogs. This only had 13 dogs, but I think the data are the same. So and I just couldn't find the presentation where we have all 28 dogs, all 32 dogs here. And then this was 69 dogs at the end. But these animals, the ones that got plasma exchange, the vast majority of them were already on 2 or 3 immunosuppressive drugs or more. And the newer data showed that some of these dogs, about 40% of these dogs were on 3 or 4 immunosuppressive drugs at the time of presentation. There wasn't hardly any difference in the hematocrit. So I think we've got the reticulocytes here. So they're not terribly regenerative, to get into your point, Jay, at the time that they present. But this will go up. In fact, the reticulocytes sometimes don't change as much as you would like. And I think it's because, you know, you'll see an animal that's got a stable hematocrit and has a 600,000 retic count, but the hematocrit's staying stable. And the only way that I can explain that is you still have antibody around that's chewing up those new cells as fast as they're being produced. And that would be another indication that your disease is not under control yet. And what else do we got here? And I wish I'd grabbed they're more inflamed. The patients that we treated were more inflamed. So we think that the animals that got plasma exchange were actually more severe than the medically managed ones. And then this was the typical change. And so you can see there is often a drop here. So this is the mean of all these dogs. And again, I wish I was showing you the 32 dogs, but sometimes between this treatment and this treatment, if you skip a day, you'll have a pretty profound drop here. And so that's where I think you look at between day 2 and day 3 and decide whether the animal would benefit to having a closer treatment. And again, so the medically managed dogs were discharged at about day 5, it looks like here. And the other animals were discharged a couple of days later. And I had a reason why they were, but I don't remember what it was now. Oh, it's probably because we're doing the plasma exchange on, day 4 sometimes. For the animals that survive, and again, this only goes out to 21 days. We looked at survival out to 30 days. The animals that survive with medical management do just as well in time as the ones with plasma exchange. But the outcomes are different. And again, the outcomes are that most of the animals, and again, this is about the same as what we found before, that there were 2 dogs that died in the hospital. This is with the smaller data set. There was 1 dog that died from thromboembolism, and I think there was one dog that died or was euthanized because he was just crashing and the owners wouldn't go on any further. But I think we could have saved that dog as well. And here, this shows only 80% survival. But when we get to the newer data, we had 92% survival if they got more than, and that's the data that Jethro showed you. And again, I apologize for not getting the most that was what we had in 2019. I think that more recently I've presented those data from about 2023 or 24. And again, 92% survival with 3 or more plasma volumes exchanged, or with 4 plasma volumes exchanged. Less with almost all the patients that got less than 2 died or were euthanized, compared to 60% survival in dogs that are medically managed.
Do we have any of these data sets yet that you've been able to look at where your preemptive recommendations were a little bit more likely to be followed? Like, do we have data of where, to your point with the first line, where they got treatment day 1 and compared it to, where I imagine like 5-6 years ago, maybe you didn't have this problem, but it probably took more to convince your fellow internist and teams to do this treatment, right? And so sometimes
it took 8 years.
Yeah. So
for our own medicine service to decide that
it's first line,
it should be a first line treatment.
But do we have outcome or just even like quality of life or client reported outcome measure or something where you could now say, is your hospital doing it consistently enough that you do have a subset of to Jethro's, like it's early, we've they've gotten their second transfusion, we're like, nope, you qualify. Do we have any data sets where we can go back and say, it's even this much better? Like when we approach mechanical ventilation at our hospital, we see better outcomes. We get them off the vent if we put them on the vent sooner.
Yeah.
Do we have this sort of data yet where we can say these are dogs that got this treatment sooner and compare it to even ones that got the treatment where somebody kind of waited a little bit because they just weren't convinced that this was as compelling as we now know it to be?
And no, we don't have that because our hospital still drags their feet just like your hospital does, and they'll try to milk those dogs out 5 or 6 days. Every once in a while, if it's a dog that's just absolutely crashing, they may come to us in day 2 or day 3. We never get them on day 1. or day 2 of presentation. They still won't, and that's reasonable. I think, you know, you could make the argument that, you know, some of these dogs do respond, you know, to initial pred and transfusion. And again, that I think that's reasonable to do that. My personal biases are that, you know, the ones that come in that are really severe, the plasma exchange ought to be the first thing you do to them. But we haven't been able to convince our people yet to jump through that hoop. But just like your ventilator patients, I think the outcomes would be even better if we got to them at first presentation, or when the word gets out that these animals get referred sooner and the referring veterinarian hasn't treated them for 5 days before they come to your hospital and get hospitalized for another 3 days before they get plasma exchange. I'm still looking to see if I can find the more updated data, but that gives you some flavor. And again, I wish the data didn't change between those. The numbers got better, but for some reason it's just I grabbed the wrong.
Well, he's looking at that. The other comment I'd have, kind of unrelated to this part, is when I've had these small guys that I've had the blood prime, it's always been a little bit of an internal struggle for me, knowing that blood products are a valuable resource. They're usually euvolemic, and so, you know, I'm using the Prismax and membrane based for my guys, but the circuit is still 130 mils. So I've got a presentation on a little like 6 kilogram dog that I blood primed with, and I wasted half of, you know, I didn't rinse back the entire volume, just out of fear of the complications of volume overload in that patient as well. And so that's always been one of those like struggles for me. I'm like, all these red blood cells are going down the drain.
Well, you can run that on
could take some plasma out, I guess.
You could, well, no, you could, on the rinse back, you know, rinse back as much as you want, but you're going to run into volume problems. You know, you have to be careful of that. But then you can just take and run the rest of that that rinse back into a sterile blood bag and use that to prime the machine the next day. It'll be good in the refrigerator overnight. I mean, you wouldn't keep it longer than that, but that's another strategy.
But only for centrifugal-based systems, right? Citrated treatments. You would recommend that because not in a heparin-based treatment. You wouldn't want to save the rinse back, right?
Why not? You might have to add some citrate.
I was going to say, you probably have to add citrate, yeah.
Well, what I'm suggesting is you collect it in a blood bag that'll have citrate in it.
Fair.
A blood collection bag. Well, that was hopefully a good, I still haven't found this presentation, but I'm not going to waste your time anymore. But because the final data are the data that Jethro showed you with the outcomes. And but I think there are two messages. One, we have to get the message out to referring veterinarians that, you know, after a couple of blood transfusions, you're probably not going to do anything more than waste more blood, and they should be referred to a center that can do the plasma exchange. And then the sooner when they come into your hospital, the sooner you get them on the machine, I think the better. At least that's the approach that I think is appropriate.
I mean, it seems like this is, from your experiences and what we know, care that we'd like to get to for, you know, having a highest standard thing. I think sort of a nice silver lining, if there is one, to our current blood supply shortages. I mean, even at MedVet, we've had to create our own blood banking to make sure we have sufficient blood supplies. But I do think as that blood supplies shrink, this gives us even more opportunity to say, like, no pack red cells. I mean, I know plasma is part of that, but a lot of times we have freezer fulls of plasma just, you know, that never got utilized because the pack reds are the more prioritized thing in a lot of these disease treatments. And so for us, it's, you know, if we've got plasma to use, but we don't have pack red cells, does it make more sense to start these treatments sooner so that we can preserve our blood supply?
Yeah, the other point that I've made over and over again, and it was in that presentation. If I were able to call it up again, maybe I can do that quickly. Is that if you can give, and I can call that up quickly. If you can give that blood as a replacement solution rather than as a transfusion, you get more bang for your buck. I thought I saw it here in this one.
You had it in there. I saw it because it's one of my favorite slides. There's a couple of slides in that presentation. One, the agglutination coming down the plasma volume exchange. That slide's just beautiful. And then this one, the more bang for your buck slide, is another good one.
And, I just called that same. Oh, here it is. Let's see if I can show that quickly. And I'll share again.
Which circles back around, I think on the critical care front, the volume that we're giving these euvolemic patients when we're transfusing, whether we're doing plasma exchange or not, this is another really key part to that, because I think a lot of our patients end up getting a volume burden that is challenging for them.
When I do the same for dialysis. If I have an animal, we have a rule that we won't dialyze an animal that has an hematocrit less than 18. And so, you have an animal with a low hematocrit and you're going to put them on the machine, you're going to want to give them a transfusion. But if we do the transfusion ICU, it's going to take 4 hours to do that. So I would take some of that blood and just blood prime the machine and do it that way, then I can get them on quicker. But the other advantage, so if you do a transfusion, what happens is, so let's say that this is your you got this low hematocrit and this is your trans.
Do you want to share your screen?
Oh, I thought I was sharing it. Sharing now.
We got it.
So here's your blood, here's your intravascular volume. We'll just say this crit tube looking thing is your intravascular volume. You do a transfusion, you add that volume to your existing volume. You do increase the hematocrit, but you do it at the expense of increasing blood volume. And my observations have been both doing blood priming and doing transfusions as replacement solution rather than as transfusions. I think I just don't see I don't see the reactions. So my bias is that most of the transfusion reactions we see, even the fever and the vomiting, are due to changes in blood volume rather than incompatibilities. Now, I grant that there could be incompatibilities, but I think that the transfusion reactions are more commonly related to the volume than they are the incompatibilities. When we do it as a blood prime, I got to do it here. We take out this chunk of plasma, and then we add that blood into that volume, and so we get an even greater increase in hematocrit because we haven't diluted those cells as much, and we do that without increasing intravascular volume, and so all the complications that would occur from overexpanding these patients go away. So if I can, and I know the animal is going to need a transfusion, say like in this IMHA patient where the hematocrit, on the machine is holding about 20%, but we don't want to send the patient back to the wards that way, then near the end of the treatment, I'll give that blood that I was going to give as a transfusion as a replacement solution, and you get a huge increase in hematocrit, and you get that huge increase in hematocrit in 15 minutes, and without any complications, and then typically those cells will hang around longer because they're at the end of the treatment.
So if I'm understanding this correctly, instead of replacing plasma at this stage, you've done your 1.5 plasma volumes, and then you just let the machine run longer and you give pack reds as your replacement solution?
Not at the very end. So near the end of the treatment, instead of using plasma or some other replacement solution, then I use pack red cells. But then I usually then do a little bit of the plasma at the end just to wash those cells back into the patient. So before you use all of your plasma, save a little bit of that, so that you have some plasma that you can wash, you can rinse out the, you know, the lines to the back to the patient, get the blood that's in the lines back to the patient. And then, and this is, you get much more efficiency with your blood products than you would if you do it as a transfusion. Well, once again, a simple question. Thank you very much for bringing up the topic. A simple question has given us an hour's worth of discussion here, so appreciate that very much, Andrew.
We appreciate it. It was a good recap, especially this was a big case. These are my two residents sitting behind me. And we were all involved in this case, so it was a good kind of recap for us, and definitely some learning points that we can take forward.
Well, I hope it was instructive, and I hope we're not making you drink the Kool-Aid inappropriately. But this, Jethro, how much
It's been your goal for the last 3 years, Larry.
I'm all Kool-Aid at this point.
It's working.
Oh, good. Well, hopefully we'll make some good, some good inroads into this horrible disease. And it's really interesting because this is a category 3 disease on the human side, but again, I think it ought to be a category 1 disease for us. And it's a category 3 disease in human medicine because they don't see it as commonly as we do, and there's just no literature at all. So they wouldn't bump it up to a category 1 without some randomized controlled trials. But I could tell you a really, if you want to hang on for a couple of seconds, I'll tell you a really cool story. So I've been invited to these, and you ought to think about going to this meeting, which would be, I think it's in February. It's in San Diego, so it's a beautiful venue to come to every year. It's called the EAAT Essentials and Advancements in Extracorporeal Therapy, I think. EAAT, or Essential Advancements in Apheresis Therapy. And it's by UCSD puts it on. So I've been invited to speak at that meeting for about the last 8 years. And about a year or two ago, I presented some of these data. It was in a context of telling them how we do veterinary apheresis and stuff like that. But I presented our IMHA data. And then they have this session where they have all the speakers, all the bigwig speakers. And this group draws all of the really big names in apheresis medicine to this meeting. And they all sit up at a panel, and then they invite the audience in advance, the audience that's planning to attend the meeting, to submit case reports. And then the cases are presented anonymously to this panel, and and then they discuss the case. Well, they had this case of a 35-year-old woman that presented practically in a coma with a really severe anemia, and there were all these speculations about what the cause of the anemia was, and then it got to the question, is this an autoimmune mediated disease, or what was this, and should they or should they not plasma exchange this patient? And the panel had come up to the decision, no, they didn't feel that it was necessary, appropriate to plasma exchange the person. And fortunately, I'd given my presentation, an hour or two before this one, and somebody yelled out in the audience, "Cowgill, what would you do?" and they, just like in your hospital, they had delayed and delayed and delayed. So now this patient was about 5 days into hospitalization and about 5 transfusions into her therapy, and still hemolyzing these cells. And so this somebody just yells out into the audience, "Cowgill, what would you do?" And I said, well, I would have apheresed her on the first day if it were my patient. And I was in the audience because I wasn't, fancy enough to be sitting at the big table at that point. And so then it turns out that the person who submitted the case was actually in the hospital. And they knew that. And so they reached out to her in the hospital. They said, Dr. So-and-so, what did you do? And he says, well, we did apheresis her, and then she got immediately better, and she had this autoimmune hemolytic anemia. And then when we walked out of the meeting for the coffee break, everybody's patting me on the back, and all of a sudden my stature had gone way, way up. This veterinarian diagnosing and recommending the management of human patients here. Anyway, that was a good day. Okay, with that selfless adulation, we should quit this meeting.
It gives us hope that translational medicine is sometimes needs to lean into their veterinary counterparts for sure.
You know, we're ahead of the game in many cases, and I think where we're already ahead of the game is with hemoperfusion. That I went to the International Society for Apheresis just a few months ago, and this meeting in San Diego where I had been presenting data on plasma on hemoperfusion. The organizers of the meeting wanted me to change my title. They say, you know, hemoperfusion isn't apheresis. And I kept saying, no, it really is. And then this year I go to the international meeting, half the meeting was absorption. I mean, it was, and so we've been there for a long time before on the human side, particularly in the United States. In Japan and in Europe, they're a little bit ahead of the United States, but there are many, many products and lots of new technology and lots of exciting things coming with absorptive technologies in the very near future. And to that, well, I'm going to leave it there. I had another comment, but I'm going to leave it there. All right, guys. Thanks so much.
Cool.
It was a great session.
Good to see you guys.
Thanks.
Bye.
Bye.